been quite shocked. And as you see, we need to make sure that the pandemic is being addressed. But in the meantime, we should not forget about other infectious diseases, and particularly in hepatitis. In advance to the World Hepatitis Day, which is tomorrow, we are launching this compendium, which is including four examples from 18 countries of our region, from national programs, from civil society, from key populations. And we look at different criteria in terms of sustainability, in terms of effectiveness, efficiency, but also addressing the key population equity, and how these examples need to be replicated. We have very important partner, World Hepatitis Alliance, as our key partner, and it's my pleasure to give floor to Kerry James, the CEO of World Hepatitis Alliance, for his welcoming remarks. Kerry, over to you.
Hello, thank you, and thank you for the invitation to take part in this important session today. So as Sud said, my name is Kerry James. I'm the Chief Executive of the World Hepatitis Alliance, and we're a network of patient-led, passionate patient-led organizations around the world, with a significant number in Europe. And our mission is really is to harness the power of people living with viral hepatitis to achieve its elimination. And in Europe, we're very lucky to have such a wealth of community organizations and civil society networks that deliver services tirelessly throughout the year and on World Hepatitis Day. But of course, the COVID-19 crisis has really interrupted the work that we were doing, and it's created new challenges and new barriers to overcome. So as the Alliance, and in order to support our members, we really wanted to find out how the COVID-19 crisis was affecting the provision of services. So we really had four main objectives. One, to see how civil society services were being affected. Two, to measure the impact on people living with viral hepatitis. But also to look at the various factors that were in play and see which ones had the greatest influence. And finally, to gather examples of best practice for dissemination and to inform the work that we were doing. So we created a very short questionnaire earlier in the year, just 13 questions, and it was distributed through our networks and through our social media, but also other people and other stakeholders also distributed it. So it actually got spread out a lot wider than we thought at the beginning. And we ended up with 128 responses from 32 countries, including 9 European countries. And really the responses in Europe really mirrored the responses kind of around the world. There were reports of, increased stigma around COVID-19 as an infectious disease, something that people working in the hepatitis space knows very well, but also around intravenous drug use. And that, like many issues, if not all other health issues at this time, viral hepatitis was kind of fading into the background. And although people were really making efforts to contact patients by telephone, there was really a lack of information to reassure those patients and to give them the information that they needed to feel contented. So if we look at that concept of information at first, and this was something that we definitely identified at the Alliance at the beginning of this period, the beginning of March, was that there was a real lack of information for people living with viral hepatitis around COVID-19. And the survey definitely showed that was a problem around the world and in Europe, with only 25% saying that there was information available. And again, it was widely reported that, that people weren't talking about viral hepatitis, that there are real questions around whether people with viral hepatitis were more at risk of COVID-19. And some civil society organizations, this particular one in Bulgaria, were taking it upon itself to translate what little information there was. So this was obviously a huge gap. So in April of last year, we created an information hub at worldhepatitisalliance.org/COVID-19, where we would signpost and collate all the guidelines from around the world for people who are living with viral hepatitis, the risk that people, increased risk of mortality from COVID-19, and also the information around key communities like migrants and people in prison. So please do check that out if you'd like more information. So we wanted to find out about services, and not surprisingly, just about everyone reported that their services had been affected by the epidemic, and they were evolving their services in order to meet the challenges of the current situation, but also to meet the needs of their communities. So this included, advocating for things like accommodation and food, which maybe wasn't a primary area where they worked in before. And in the UK, they were even topping up people's telephones of the most vulnerable people to make sure that they could access online and telephone support, that they had the phone was available. And they were also involved in delivering food and accommodation, satisfying accommodation needs. Many projects have been postponed, and work for homeless and PWIDs were definitely increasing in several areas. And of course, it was not just a health crisis, but it's also an economic crisis in many countries. And many people found that they were out of jobs, that they were had reduced means. Maybe they were going to be having problems with their housing. So these were all issues that became part of the practice of civil society organizations in Europe during this time, so they could best serve their communities. So next, we wanted to look at treatment access. And while it was great that almost 2/3 said that people could access treatment, a worrying third said they were unsure or no. And as you can see here, there were different situations in Europe, with certain countries reporting that they did feel that people had access, but then other countries either no or were uncertain. And the biggest reason why people felt they weren't accessing treatment was because of travel restrictions, because they couldn't reach the hospitals or the pharmacies in order to pick up the treatment. But I'd just like you to notice on the right-hand side, the bar that relates to people avoiding healthcare facilities because of fear of COVID-19, because this is an issue that's going to come up again, and is something that is going to linger on after the mortality rates and infection rates decrease. So here's just a couple examples of there not being public transport or cars. And again, civil society adapted their practice in order to reach these needs. And the UK reported delivering medications not only to people's homes, but also to places where homeless people were, in camps, to make sure that people that were already on treatment were receiving the treatment that they needed. And when we looked at testing, again, there was a mixed bag across Europe, with some countries reporting that there was testing available, with other ones being either not sure or reporting there wasn't any testing available. And you'll see that the number one reason that people said that this was happening was this fear of accessing healthcare facilities. And as I said, even, this is something that even when the hospitals and the testing facilities open, this fear could very well remain. And a survey by UHC 2030 about the inclusion of civil society in the COVID response found that very few countries are actually using civil society organizations in order to deliver COVID services. And as we move forward, and as we look to scaling up screening and vaccination and care, these are all things that civil society organizations working in hepatitis are experts at, and they're trusted by their communities. So it's really going to be important for governments to engage these civil society organizations if they really want to serve the communities and have an effective response. So just some observations. There's definitely been a huge impact by COVID-19 of the services that are available. It's definitely impacted people's access to treatment. But I think the really heartening thing is that civil society organizations have absolutely stepped up and evolved their practices to meet these new needs of their communities. This reluctance to access hepatitis-related services because of COVID is something that's a very, very strong motivator, and something that civil society organizations in the future can look to overcome. And there definitely was, especially at this time, an information gap for people living with viral hepatitis. And this is something that I think everyone needs to kind of look at and try to address. So it's World Hepatitis Day tomorrow. So we have lots of materials online for social media graphics to Zoom backgrounds available in multiple languages. So please have a look and please download and use them at worldhepatitisday.org. And I just want to say thank you to all the civil society organizations for their tirelessly serving their communities, people living with viral hepatitis, and the team at WHA for conducting this great piece of community research. So thank you for listening.
Thank you very much, Carrie, for this excellent presentation, timely, talking about the COVID-19 impact on communities and particularly in hepatitis response. That's food for thought for all of us to think and reflect, and for national programs and also key partners to see how we can modify these services in terms of testing, as we are missing millions of people as a World Hepatitis theme of this year, and also the fact that we need to move forward even during COVID-19 to address the hepatitis. We have vaccines. Hepatitis B can be addressed through vaccination. We have cure for hepatitis C, and it's revolutionary. And how we make sure the testing and treatment is available, and also in a destigmatized manner, because if the communities are not engaged, we will see a stigma and also deprioritization of the hepatitis response. And that's something we don't want, because then not only we will miss the targets of 2030, but also we will have a rise of hepatitis C and B, and also its impact in terms of liver cancer and millions of people who may die globally. So with those words, I give back floor to Nicole. I didn't see any specific question to your presentation, but I think that still, colleagues, if you have questions or comments, particularly in terms of how to adapt the services, including digital health, for example, or mobile clinics and so forth, please do send your suggestions, your own examples, or your own thoughts with us. If fine with you, Antons, I hand over back to Nicole and you two for the next part of this session. Nicole, over to you.
Yes, good morning, everyone. Can you see my screen? I just shared the screen. Let me know if it's clear.
Yes, just need to enlarge it and it works.
Yes. Is it better?
Yes, thank you.
Yeah. So first, thank you to everyone. I think we have more than 80 participants from different countries of the region, so that is great. And I'd like to recognize that you're busy with COVID and other things. So thanks very much for your attention today for the launch of this regional compendium of good practices. So I'll just give you some updates on the WHO undertaking and around hepatitis. For those who are not extremely familiar, you know that hepatitis A and E is transmitted through injection of contaminated food and water, and hepatitis B, C, and D through contact with contaminated blood or body fluids. Hepatitis B and C are mostly asymptomatic and responsible for approximately for a high number of deaths, extremely high number of deaths due to viral hepatitis in the world. This is the reason why we call that a silent epidemic. So in our region, we have about 15 million people living with hepatitis B and 14 million people living with hepatitis C. Hepatitis B causes 56,000 deaths per year, and hepatitis C more than 100,000 deaths per year due to liver fibrosis, cirrhosis, and liver cancer. The highest load of patients is in Eastern Europe and Central Asia. In terms of intervention, we have vaccination program in most countries of the region for hepatitis B. That is a very strong intervention for preventing transmission of hepatitis B. And as you know, we have cure for hepatitis C now. In our region, people at highest risk are injecting drug users, people living with HIV, and people in closed settings and prisons. We still have a number of transmission in healthcare settings. As opposed to TB, HIV, and malaria that had seen a decline in death over the past years, in 2015, hepatitis deaths were still increasing. This is why, together with the high burden of hepatitis globally and the new tools that we have for preventing and treating hepatitis, WHO headquarters, I developed a global strategy on viral hepatitis in 2016, together with the global strategy for HIV and STIs. These strategies aim to eliminate hepatitis by 2030 as a public health threat and follows the universal health coverage framework, the continuum of health services principle, together with the, of course, a public health approach to testing and treatment of the disease. We have developed, as the regional office, the European Action Plan on viral hepatitis that follows the 5 strategic directions of the global strategy. The first one is to have good data, information for focused action, good estimates of the burden of disease, and better monitoring of the program coverage and impact. The second strategic direction is about intervention for impact, that is about service delivery model for testing, treatment, and prevention. The third strategic direction is about delivering for equity, which means leaving no one behind, especially people who use drugs, people living in prison, closed settings, and people living with HIV. The fourth strategic direction is about financing for sustainability, finding resources for country programs. And finally, the fifth direction is innovation for acceleration that includes implementation research to scale up interventions that have proven to be effective. So we came from a global health sector strategy for hepatitis to a regional action framework and a national strategy or plans to guide countries to address prevention, testing, and treatment towards elimination by 2030. So globally, we made tremendous progress through different global summits and conferences. In 2017, we had 82 countries with national plans, and we had our first regional consultation on viral hepatitis in 2019. In our region, now in 2020, we have 33 countries with national hepatitis plan and 15 more countries in the process of developing their plan. We've provided, and Anton has provided, excellent support to countries to develop these national plans. And this is the key to ensure first funding and result and impact. We have a number of targets for 2020, and we're on track for a number of those targets. We have strong vaccination programs, reasonably good PMTCT program, good blood safety and injection safety. We are lagging behind with harm reduction and for hepatitis B diagnosis and treatment. We're making progress in terms of diagnosis and treatment, but we also need to recognize that we have to strengthen our monitoring system to be able to show our progress. The bottleneck that we have, and we still have in some countries, are the complexity of testing approach to diagnose, some still invasive tests, and in some countries still remaining high cost of diagnosis and treatment, despite the fact that we now can use generic in some countries and have more affordable treatment. So globally, we have developed all the tools for diagnosis and treatment. I'm going to show in the next slide. So from 2015 to today, we have had a number of guidelines that have been updated, injection safety campaign. We have cost effectiveness calculators to help countries understand, with the current treatment available in countries, what is the cost effectiveness of the program. We have in 2019 consolidated strategic information guidelines to be able to monitor the program progress. And the latest guidelines is about HBV PMTCT recommendation on antiviral medicine use in pregnancy. So regarding this prevention of mother-to-child transmission of HBV, the old recommendation from 2017 is, of course, the birth dose of vaccine within 24 hours of birth, followed by 2 or 3 dose vaccine to complete the vaccination series. So, we also have guidance on testing pregnant women, particularly in intermediate and high burden countries. What is new in the 2020 guidance is the recommendation on the use of antiviral tenofovir for pregnant women who have a high viral load monitored by HBV DNA. And if HBV DNA is not available, to treat pregnant women who have HBe antigen, same treatment with tenofovir prophylaxis started from the 28 weeks of pregnancy to prevent mother-to-child transmission. So these guidelines, global guideline, will be launched tomorrow, and there will be a technical briefing webinar on the 31st of July. And we welcome your attendance, and please let us know in the chat if you're willing to attend this webinar. We're going to send a link to you in the coming days. As Carrie mentioned, during the COVID pandemic and particularly the lockdown, we had a number of issues of access to services, and the role of WHO and our team was to ensure the continuity of essential services in terms of vaccination, diagnosis and treatment, PMTCT and harm reduction. We've tried to provide continuous support to member states in our region and work closely with our WHO health emergency programs for the response and recovery. Just to mention here a document, this is available on our website. This is the latest issue of a guidance on maintaining essential services for many diseases, including hepatitis. So what to do during the lockdown and how to transition towards restoration of activity after the lockdown. So just to list 1 or 2 recommendations: to prioritize testing for people with symptoms and also high-risk groups, and also to provide multi-month dispensation and full course of treatment for HCV to avoid interruption of treatment during the lockdown. So tomorrow is the World Hepatitis Day 2020. We are looking this year into the hepatitis-free future. There will be an emphasis on the immunization. That is a very important intervention for prevention of hepatitis B transmission. So some of the point will be that vaccine works to protect hepatitis B and its complication, including liver cancer. If we want to fight liver cancer, we need to strengthen immunization. Vaccination of newborns and infants, again, hepatitis B saves lives. And of course, as Carrie mentioned, we have the issue of maintaining services, including immunization services, but also key testing and treatment servicing during COVID. So for our region, we will emphasize the immunization PMTCT work, but also testing and treatment efforts towards elimination. So now the compendium. The compendium of good practices in the health sector response to viral hepatitis. It's an effort that we are really committed to in the regional office. Our joint TB, HIV and hepatitis team has had the habit of developing compendiums. The first on HIV in 2018, followed by one in 2019 on TB. And the first on hepatitis was started in 2019 and will be available on our website tomorrow, most probably. We have been able to document 34 good practices from 18 member states, from national hepatitis program, from healthcare providers, academia, NGOs, etc. We had a committee to select the good practices from the countries with a number of criteria. The required criteria were relevance, sustainability, efficiency, and ethical appropriateness. We also looked at gender and equity, effectiveness, possibility for scale-up, partnership, community involvement, and of course, political commitment. Of those 34 good practices, we have a reasonable representation of the 5 strategic directions of our regional plan. In particular, the second one on the intervention for impact, that is about service delivery models. The topics, we have, of course, national immunization programs, service delivery models, innovation and accessibility, but also synergy and intersectional collaboration, social transformation, social return on investment, health in prisons, and access to medicines. And during our discussion today, we will have several illustrations from these different topics from different countries. So just to conclude, that was a team effort to gather and select these country good practices. First, I would like to thank the countries, all the representatives from the countries who provided this information of your best practices. This is very important for us to be able to share and fertilize your experience with other countries. I would like to thank my colleagues, particularly Antons and Marcelo, who have dedicated a lot of time to make this happen and be able to share this good practice by today and tomorrow. Thank you very much for your attention.
Thank you very much, Nicole, for a great presentation. Just to remind that there will be a webinar on the new WHO guidelines on hepatitis B prevention on Friday. We don't have the details yet, but if you are interested to join, please indicate it in the chat or send an email to me or Marcelo, and we will share the details as soon as it will be available. So if there are no urgent questions to Nicole or to Carrie, then we will proceed to our next session and to the session which is dedicated to several of the good practices that we managed to invite the presenters today. There are some other practices will be featured in our website. There will be a practice from Luxembourg and a web story about comprehensive prevention in Luxembourg prisons. It will be published on our website today or tomorrow, and there will be also another web story about mobile services in Spain, which will be published also today and tomorrow. So, but then returning to the program of our webinar, we would like to invite Dr. Vysotskaya from the National Center of Hygiene, Epidemiology and Public Health Center in Belarus, in Minsk, who will present about the ensuring high level of hepatitis B immunization coverage in Belarus, and the presentation will be in Russian language, so all other colleagues might need to use the interpretation button, which is in the bottom of your screen. You have to choose the English interpretation and probably also put the mute original audio to make it clearer, and so we will have a presentation in the Russian language. Вероника, если вы готовы, можете...
Да, здравствуйте. Меня слышно?
Слышно отлично.
Да, хорошо,
Можете поделиться
спасибо.
экраном. Вы можете...
Да, сейчас я... Что-то видно? Хорошо. Здравствуйте, уважаемые коллеги. Благодарим за возможность принять участие в вебинаре и поделиться с вами сведениями о результатах программ вакцинации против гепатита Б в Республике Беларусь. Позвольте немного сказать о нашей стране. Наша страна располагается в Восточной Европе, численность населения ее около 9,5 миллионов человек. К началу реализации программ иммунизации против гепатита Б наша страна относилась к категории стран с умеренным уровнем распространенности гепатита Б. При этом заболеваемость различными формами вирусного гепатита суммарно составляла более 80 случаев на 100 тысяч населения. Наиболее массовые программы вакцинации против гепатита Б начали реализовываться в нашей стране поэтапно с 1997 года и вначале характеризовались селективностью подходов. Вакцинация была ориентирована прежде всего на отдельные возрастные и социальные группы населения, которые подвержены максимальному, наибольшему риску инфицирования. Это дети, рожденные от HBs-позитивных матерей, это медицинские работники, которые имеют контакт профессионально с биологическим материалом, это лица, которые являются донорами крови и ее компонентов. С 2000 года вакцинация против гепатита Б была включена в национальный календарь профилактических прививок нашей страны, и сначала она проводилась и стала проводиться всем новорожденным детям в первые 24 часа после рождения. Это было до 2007 года. С 2007 года по настоящее время в нашей стране вакцинируют в рамках национального календаря всех новорожденных детей в первые 12 часов после рождения. Помимо этого, начиная с 2007 года у нас действует вакцинация, так называемая, по эпидемическим показаниям. И дополнительно необходимо отметить, что до 2018 года у нас работала трехдозовая схема вакцинации. С 2018 года мы перешли на 4-дозовую схему вакцинации новорожденных детей. И таким образом, в настоящее время национальный календарь, в рамках национального календаря профилактических прививок вакцинация против гепатита Б осуществляется в первые 12 часов жизни с использованием монокомпонентной вакцины против гепатита Б. И далее новорожденные получают 3 прививки в 2, 3 и 4 месяца в составе комбинированной вакцины, которая содержит компонент против гепатита Б. Помимо того, что у нас реализуется национальный календарь вакцинации, вакцинация по ЭПИД-показаниям, в нашей стране еще реализуется вакцинация так называемого пока рекомендательного характера. То есть это для граждан определенных групп, например, это лица, которые находятся в семейном или сексуальном контакте с позитивным, HB-с-позитивным лицом. Это потребители инъекционных наркотиков, МСМ, ВИЧ-инфицированные лица. Также лица, которые готовятся к плановым операциям с возможностью переливания крови, и лица, выезжающие в эндемичные по гепатиту Б страны. Масштабное проведение плановой вакцинопрофилактики гепатита Б среди новорожденных с 2000 года, а также вакцинация отдельных групп, о которых я говорила, увеличили, безусловно, иммунную популяционную прослойку, косвенным показателем которой является величина охвата профилактическими прививками. По состоянию на 1 января 2018 года показатель охвата в целом населения профилактическими прививками против гепатита Б у нас составил 37%. В когорте детского населения до 18 лет показатель охвата законченным курсом вакцинации уже на протяжении многих лет у нас не опускается ниже 98%, что соответствует рекомендациям Всемирной организации здравоохранения. В течение последних 5 лет ежегодно в нашей стране регистрируется чуть более 1000 случаев инфекции гепатит Б, из которых более 90% приходится на хронические и латентно текущие формы. То есть это как раз те формы, которые и поддерживают циркуляцию вируса гепатита Б в популяции. При этом многолетняя динамика заболеваемости острым гепатитом Б характеризуется достоверной выраженной тенденцией к снижению. И показатели заболеваемости данной формы гепатита у нас остаются стабильно низкими уже на протяжении более 5 лет с колебаниями от 1,5 и до 0,6 случаев на 100 тысяч населения. При этом еще хочется сказать, что до 2012 года показатели носительства HBs-антигена превышали как заболеваемость острыми формами, так и заболеваемость хроническими формами гепатита Б. С 2014 года отмечается постепенно нарастающее превалирование показателей заболеваемости хроническими формами, и в определенной мере, конечно же, эта ситуация является следствием улучшения диагностики хронических гепатитов. Проведение вакцинопрофилактики с обеспечением оптимальных уровней охвата среди детского населения создало предпосылки для эффективного управления эпидемическим процессом гепатита Б. При этом в последние 2 года, в 2018 и 2019 годах, в нашей стране регистрируются минимальные за период наблюдения уровни заболеваемости острым гепатитом Б, которые, если посмотреть в ретроспективе, в 27 и 16 раз ниже аналогичных показателей 1996 и 2000 годов. На фоне снижения общей заболеваемости гепатитом Б, заболеваемость общая, то есть всеми формами гепатита среди детей в возрасте до 15 лет, сократилась в 53 раза и острыми формами почти в 83 раза. Установлена обратная сильная корреляционная зависимость между уровнями заболеваемости острым гепатитом Б и охватом профилактическими прививками среди детского населения. Данный факт вполне согласуется с данными других исследователей. Также необходимо отметить, что на протяжении последних лет в возрастной структуре заболевших у нас отмечается существенное увеличение доли вовлечения в эпидемический процесс лиц более старшего возраста, где-то старше 30 лет. Охват вакцинации которых, согласно предыдущим слайдам, значительно ниже, что закономерно, учитывая сроки начала массовых кампаний вакцинации. То есть это еще раз подтверждает правильность пути, на котором мы стоим. Таким образом, текущие итоги реализации программы иммунизации против гепатита Б в нашей стране таковы, что у нас достоверно снизился уровень заболеваемости острым гепатитом Б, заболеваемость острыми формами гепатита среди детей снизилась практически до единичных случаев или их полного отсутствия в отдельные годы. При этом у нас уровень заболеваемости хроническими и латентными формами гепатита Б среди совокупного населения снизились более чем в 2 раза, и они остаются практически на одном уровне на протяжении последнего десятилетия. И следует понимать, что развитие эпидемического процесса у нас определяется хроническими и скрыто протекающими формами, которые при этом имеют высокую медицинскую и социальную значимость на фоне снижения заболеваемости острым гепатитом Б. Национальная стратегия в отношении вакцинации гепатита Б, которая направлена была и теперь продолжает быть направленной на предотвращение вертикальной передачи инфекции и передачи инфекции на протяжении всего детства, а также профилактика инфекций среди взрослых, являются оптимальными с позиции Всемирной организации здравоохранения и в дальнейшем будут поддерживаться в рамках нашего календаря прививок. В качестве перспективных задач для нашей страны мы рассматриваем продолжить динамическое слежение за развитием эпидемического процесса инфекции и динамическое слежение за состоянием специфического популяционного иммунитета к вирусу гепатита Б, что позволит нам оптимизировать подходы по формированию комплекса профилактических мероприятий с учетом современных эпиаспектов инфекции. И хочется поблагодарить Европейское региональное бюро ВОЗ за то, что в 2020 году при вашей поддержке начата подготовка к проведению сероэпидемиологического исследования по вирусному гепатиту Б с целью оценки воздействия вакцинации на эпидемический процесс этой инфекции в нашей стране. У меня все. Благодарю за внимание.
Большое спасибо, Вероника. Сейчас я включу видео. За отличную презентацию. Может быть, хочу еще добавить, что наша штаб-квартира в этом году выбрала темой Всемирного дня борьбы с гепатитом именно вот борьбу с гепатитом Б и с профилактикой перинатального заболевания, инфицирования гепатитом Б, поэтому это очень актуальная тема. Как мы знаем, во многих наших странах удалось достичь существенного снижения распространенности среди детей. И, как вы знаете, так, у нас есть также региональный процесс верификации достижения цели контроля гепатита Б посредством. Мы сейчас работаем с несколькими странами для того, чтобы это документировать посредством проведения сероэпидемиологического исследования среди вакцинированных когорт. Да? Немного вот пандемия COVID-19 эту проблему, этот вопрос как бы осложнила, но мы будем дальше работать. So, dear colleagues, I will switch now back to English, and I think we can keep all the questions to Veronica and to other participants to the end. And now I would like to invite Dr. Maya Butsashvili to present about of hepatitis C treatment to harm reduction services in Georgia. As you know, Georgia is one of the flagship countries in our region because of the national hepatitis C elimination project, and that they produce a lot of evidence, a lot of interesting examples. And this will be one of the examples which is dealing with vulnerable population of people who inject drugs, and how the services and the access to treatment can be improved through integration to harm reduction services. So Maya, are you able to share your screen?
Yes, I will do it right now.
Maybe in the meantime, if it's fine, while you're putting the presentation, there was a question about hepatitis C treatment in Ukraine to carry. Did your survey, Zohed was asking this, in Ukraine showed that some patients were not following the treatment because of COVID-19?
We didn't get any information like that from the survey, no. But I think there's definitely challenges around treatment initiation, especially if there's a lockdown in place, you know, whether people can get the treatment or start it. There were lots of reports, not from the Ukraine, but from other parts of the world of treatment initiation for hepatitis C being delayed because of the restrictions, and also civil society organizations and hospitals just not doing the screening because they know that the treatment pathway isn't open. So there's definitely lots of things going on, but I don't have any particular insight into Ukraine specifically.
Thank you very much.
I suggest we can have also a discussion, because we have several participants, attendees from Ukraine, and they can share their experience. But I think now we should proceed with the next presentation. Maya, can you share, or I can share for you if there are any problem? Okay, good. I think Maya, you must be muted.
Maya, could you please unmute yourself? Yeah,
Okay.
you are.
Okay. So Georgia has very high burden of hepatitis C infection, maybe one of the highest in the world, with prevalence of 7% and chronic prevalence of more than 5%. And people who inject drugs are the largest portion of infected persons. So according to the BSS from 2017, prevalence of hepatitis C among this population is more than 63%. So from 2015, we have elimination program of hepatitis C led by Ministry of Health of Georgia, and technical assistance is provided by US CDC, and medications are provided by US company Gilead. So in 2018, Ministry of Health created HCV treatment decentralization group, which has two subgroups. One is harm reduction group, and another one is primary care group. So HCV decentralization in these two groups started from 2019, and the main purpose was to increase coverage of HCV treatment and decentralize, because before that, treatment was only available at specialized clinics. So by this group, simplified diagnostic algorithm was introduced. I will not go into details, but here you see the chart where diagnostic tests are provided. In regular treatment sites, diagnostic algorithm was more complicated at the time and more tests were provided. As for decentralized sites, we're providing less tests and more simplified model of diagnostics, and also monitoring. So at first, 4 harm reduction centers were enrolled as a pilot sites where PWID could get diagnostics as well as treatment. So medication was also released on site at harm reduction sites. So to evaluate this process, from the start of the integration after like 10 months, we conducted patient satisfaction survey comparing satisfaction among patients who were treated at harm reduction sites to those who were treated at regular specialized treatment sites to look at the differences. So overall, 358 patients were enrolled, almost half and half from harm reduction sites and specialized treatment sites. So the similar proportion of these patients, about 85 to 88%, said that they did not face any barriers to enrollment in the elimination program. So both groups similarly said that they received comprehensive information about the treatment. So 95% of respondents from both groups said that they were confident that confidentiality was protected during diagnostics and treatment. So higher proportion of patients treated at harm reduction sites compared to treatment sites said that the facility overall was very good, and they were very glad with the facility. And this one also includes their satisfaction with doctors and nurses. So there was a significant difference in the time to treatment. So we calculated it by average time from viremia testing to administration of first dose of hepatitis C DAA. And we found a huge difference. So 42% of patients at harm reduction sites versus only 4.6% of patients at specialized clinics received the first dose within 2 weeks. Here we see that at harm reduction sites, they were receiving treatment much sooner. So the turnaround time was less. This was also due to the project which was ongoing in parallel, funded by FIND, and was providing on-site viremia testing for PWID, which also helped to decrease the waiting time until the first pill of DAA. So there were challenges during implementation of hepatitis C treatment integration at harm reduction sites. First of all, the regulatory phase takes very long, usually. When you want to start treatment of HCV at a certain site, you should apply to Ministry of Health to receive agreement from Ministry of Health to start this process. And this takes very long time, unfortunately, which needs somehow to simplify these regulations. Ministry of Health Regulatory Agency requested multiple rearrangements at harm reduction sites to meet all regulations for treatment integration. Because as we know, these sites, harm reduction sites, are not clinics per se. They are not serving as medical facilities. That's why all those requirements of Ministry of Health for the treatment site are not met by harm reduction sites and needs a lot of rearrangements. So it needed many steps of adjustments and took a lot of time. So what we learned from this piloting process in those 4 harm reduction sites is that quality of services and perceived satisfaction of patients receiving treatment at integration sites is high, and the services are feasible, and so it's quite feasible to expand this process at other harm reduction sites overall, I mean, throughout the country. Unfortunately, this process was stopped because of COVID pandemic, but we hope that in near future, when we will I don't know when, but when we will finish COVID pandemic, this process will continue. Here you see the map where we have this harm reduction needle syringe program sites in Georgia, and we hope that one day HCV treatment will be available at all or at least most sites throughout the country. That was all. Thank you.
Thank you very much, Maya. So we had a nice presentation about the hepatitis C services integration into harm reduction. I think we should go for our next presenter, and then we keep all the questions for the discussion afterwards. And the next presentation will be from Professor Mojca Matičić from the University Medical Center in Ljubljana, Slovenia, and she will present about elimination of hepatitis C, again, in some population groups at high risk of HCV infection in Slovenia. So, Mojca, do you?
Thank you. Yeah, can Maya close her presentation, please?
Maya, can you stop sharing? And
okay. So, good afternoon to everybody. On this special occasion, it's a great honor and privilege to present you the strategy regarding the elimination of hepatitis C at high-risk groups in Slovenia, in my country, Slovenia. So this is a small country, and within 2 million of inhabitants, 5 years ago, the estimated prevalence of actively infected with HCV was 0.3%, and 2/3 of infected reported IV drug use as the mode of infection. However, luckily enough, in Slovenia 23 years ago, the national strategy for the management of HCV infection was set up by the Slovenian Viral Hepatitis Expert Board, and since then several activities have been introduced into the routine medical practice, including the model projection towards HCV elimination. Regarding HCV treatment in Slovenia, treatment has been available as well as accessible for everybody since 1997. IV drug use has never been a contraindication for HCV treatment, and treatment is completely covered by the national health insurance system. Standard of care treatments have always been available in Slovenia on time, and DAAs were available since 2014, when also a modeling projection showed that by switching treatment to DAAs and reasonably increasing the diagnosis and treatment rates, the elimination of HCV in Slovenia was possible by the year 2030, as was the WHO goal. However, being very enthusiastic about the excellent efficacy of the DAAs, Slovenia in 2017 decided to go for a micro-elimination strategy. What is a micro-elimination? It is actually breaking down the national elimination goals into smaller goals for individual population segments for which treatment and prevention interventions can be delivered more quickly and efficiently by using the targeted methods. So, during the past 20 years, in Slovenia, the HCV seroprevalence was studied carefully, or at least estimated in several selected groups. And for the purpose of micro-elimination, we picked up the groups with highest HCV prevalence and those that were easily accessible. So we divided these selected groups into two targeted subpopulations using different strategies. In the first targeted subpopulations, there were HCV infected with regular medical supervision, such as hemophiliacs, hemodialysis patients, transplant recipients, and HIV co-infected. And the strategy in this group of patients was to make an active search for all the individuals of a selected group through registers, various database, medical records, and so on. Then to test all the individuals if they haven't been tested or cured before, and to immediately introduce DAA treatment in case of HCV RNA positivity. As for the second targeted subpopulation, there were HCV infected without regular medical supervision. These were much less easily accessible. And those were the populations such as people who inject drugs and prisoners. And the strategy in this targeted subpopulation was to adapt a cascade of care interventions for the specific needs of a particular group. So by the year 2019, so in nearly 2 years after its introduction, the HCV microelimination was 100% completed in the first targeted subpopulation. So in patients with hemophilia, hemodialysis patients, transplant recipients, and HIV co-infected. To be more precise, in hemophiliacs, the crucial issue was that they were systematically and closely managed on the national level since 1967. All hemophiliacs were screened for HCV infection already in the mid-90s, and regarding the microelimination strategy, in 2017, only an active search of the National Register of Hemophiliacs was performed. All the non-cured have been invited and treated immediately with DAAs, and most probably this is the first country in 2018 to eliminate HCV infection in patients with congenital bleeding disorders. In 2019, there were no HCV positive patients in hemodialysis units throughout the country. However, to keep this achievement sustainable, because this is a dynamic process, in 2019, a change in the national guidelines for the management of all nephrology patients was made, stating that HCV testing must be performed, and in case of positivity, immediate HCV treatment should be introduced. And regarding the HIV co-infected patients, it was not that a difficult task, because all the known HIV positive persons in Slovenia are centrally managed at the University Medical Center in Ljubljana. They're all checked for HCV infection on 6 to 12 month basis and treated immediately in case of positivity. Also, all the other still unknown HIV positives turn to get HCV treatment immediately. Regarding people who inject drugs in Slovenia, more than 60% of them are managed at substitution treatment programs. Namely, in Slovenia, in the mid-90s, a network of so-called centers for prevention and treatment of drug addiction was established regionally throughout the country, where HCV testing has also been introduced. So in 2007, these 18 centers integrated with 5 centers for treatment of viral hepatitis on the regional basis for the complex management of HCV infection in drug users. So merely 2 years after its implementation, the treatment for hepatitis C in these programs has increased by more than 4 times. And using this model, a modeling study has shown that by switching to DAAs and doubling the treatment rate, the macro-elimination in people who inject drugs on opiate substitution treatment in Slovenia is feasible already by the year 2026. However, nearly 40% of drug users are managed in other forms of treatment or other programs, such as low-threshold programs like needle and syringe program, homeless shelters, and so on. And the pilot study from the recent years has shown quite a high prevalence of HCV infection in those groups, which are less easily accessible. So the plan for the year 2020 was to increase the HCV testing linkage to current treatment in low threshold settings by using mobile outreach units. We had also another plan for the year 2020 in prisons to increase the HCV testing and treatment within the prisons by joining the forces from the Clinic for Infectious Diseases and the individual prisons. However, the COVID pandemic in the first part of the year actually posed an immense challenge not only to healthcare system but also to the affected communities. So we needed to put the projects for 2020 on hold. However, we decided not to put them on hold for more than 6 months. Put the presented figures together, by January 2020, we guesstimated that the prevalence in Slovenia of HCV infections most probably 0.2%, meaning that roughly 82% have already been diagnosed and roughly a little more than half of the infected have already been treated. Well, what are the challenges of micro-elimination? It definitely is a strategic approach which can contribute to elimination of hepatitis. It's feasible in certain high-risk populations. As for Slovenia, I hope I was clear that it has a potential to eliminate HCV as a public health problem before 2030, and micro-elimination has been completed in most of the high-risk groups. However, an increase in identifying the infected and linkage to care in people who inject drugs in low-threshold settings and in prisons is definitely needed. And in this time, we need to try to minimize the impact of COVID-19 epidemic on HCV eliminations. What have we learned from this presentation? Actually, Slovenia has 3 major milestones on its way to HCV elimination. First was setting up the national strategy for the management of viral hepatitis way back in 1997. Second, 10 years later, there was an introduction of systematic HCV strategy for people who inject drugs. And thirdly, in 2017, most importantly, the introduction of HCV micro-elimination strategy. So to summarize, the countries should start micro-elimination for at least one group by rightly prioritizing people with advanced liver disease. Thank you very much.
Thank you very much, Moica. Thank you very much, Moica, for the excellent presentation. And as always, we definitely will be able to discuss or answer some questions if there will be any questions from the attendees. But I would suggest that we proceed to our last presentation today to Dr. Julia Delano, who is Director of AIDS and HIV program in the Spanish Federal Ministry of Health, and she will present about the study about prevalence of hepatitis C in general population in Spain, which is very important for any country to have a good baseline understanding of the epidemiology in order to plan the national program. So she will tell you about the results of this survey in Spain. So Julia, over to you.
Thank you, Anton. So I believe you can hear me well and you can see the slide. Thank you to WHO for inviting the Ministry of Health to present this example of a good practice for the reasons that Anton has already anticipated. In 2015, the Ministry of Health produced the strategic plan to address hepatitis C in the national health system with the aim to reduce morbidity and mortality rates in the Spanish population. And the plan addressed prevention, diagnosis, treatment and monitoring of people with HCV infection. However, the plan acknowledged that until 2018, obviously the plan addressed that concern before, most of the studies of HCV prevalence carried out in Spain were limited to certain regions and lacked information about viremic confirmation. So there was a clear need to improve the epidemiological information to develop policies. Because you will agree with me that decision-making in public health needs to be supported by the best available epidemiological evidence, and the strategic plan from 2015 addressed in its first strategic plan to include a population-based study with which to estimate the prevalence of infection in the general population in Spain. And it is the general population in Spain that I will be referring to, acknowledging that vulnerable population of people who inject drugs or gay men who are engaging in the chemsex scenario, or people in prison setting, or undocumented migrants may have barriers to address primary healthcare, and therefore we will not be including them necessarily in this survey. They're not excluded, of course, but populations, as you know, self-select. So the study design was a population-based survey of persons aged 2 to 80 years of age, though you will see later on that for the hepatitis prevalence, the age group was narrowed, and it included a complex and ambitious sampling strategy, which is better explained in more detail in the text, and for time reasons I will not go into it, but it basically aimed to obtain a representative sample of the general population attending primary healthcare in Spain. Interviewees were approached in the blood extraction queue, and because this survey was not designed to estimate the undiagnosed fraction nor the proportion of people who were positive to hepatitis C and were not linked to care, we developed an additional strategy by sending letters to health professionals for confirmed and undetermined cases of hepatitis C infection, so we could obtain additional information regarding the case. Very briefly, we obtained information on 7,675 participants aged 20 to 80 years of age, and the prevalence of antibodies at the time of the survey, which, as you can see in the slide, is 2017, early 2018, was 0.85%, well below the prevalence in estimated prevalence in 2015. The prevalence of active HCV infection was 0.22%, and as you can see in the graph on the right-hand side, we can see sorry, before that, I was missing a very, very relevant information for decision-making and policy, and that's the undiagnosed fraction of people with active infection. That's 29% of those people who tested positive for active HCV infection did not know they had active HCV infection. And this is, of course, very important in order to guide the testing policies. When we looked at the proportion of people with active HCV infection by age and sex on your right-hand side, you can see that the rate was higher in men than in women for most age groups, men in blue, women in red, and particularly for the men aged 50 to 59%, though prevalence in this group was below 1%. And I would also like to add that the undiagnosed fraction in this group of men was 16%, lower than the average. The challenges, well, as I've already mentioned, the survey was not designed to estimate the undiagnosed fraction nor the proportion of persons unlinked to care. And this was very important because we wanted to produce a number of population estimates on which to inform the testing guidelines. So we could estimate that of close to 35 million inhabitants aged 20 to 80 years of age in Spain, for an active prevalence of HCV infection of 0.22%, we estimated there would be just under 77,000 persons with active HCV infection, but only 29% of those did not know they were infected. So the number of persons with undiagnosed HCV infection was 22,478. And we also wanted to highlight that of the people with active infection who had a diagnosis of active infection, in 17% of them, that's just over 9,000 people, we had no evidence that they were linked to care. So it's not only about testing and diagnosing people, but making sure they're linked to care and treated with the AAs. Integrating data from this survey and other data sources to develop the screening recommendations at national level was also challenging, but we've managed to do that. And conforming a multidisciplinary group with different expectations from public and regional administration, clinical groups, NGOs, scientific societies. We all had different expectations, but working together towards a common goal was challenging, but I would add also the most rewarding aspect of these groups. With this in mind, our main lesson learned was that we could generate data to feed a technical group for our first HCV screening guidelines in Spain. Our first meeting was just over a year ago, and it was integrated by a number of people. It was a large group. Initially, we thought it would be very hard to handle because we had, as you can see here, lots of different people from different backgrounds. Close to 36 people conformed this technical group July last year. But we've been working actively during this year, and on the 2nd of July, we produced the first guidance of HCV testing for Spain, general population, and of course, vulnerable groups. I want to give my special thanks to Anton Smoselewskis and Marcelo Naveira, because on behalf of WHO, they were external reviewers of this guidance, who is only in Spanish at the time, and they did this very fast and very kindly. So thank you to both of you. And of course, thank you to all the different people who've contributed to developing these two pieces of work. Thank you very much.
Thank you very much, Julia. Yeah, we are a little bit jealous for Spain for having such an excellent quality data to be able to understand the burden of disease and also to make informed decisions. Yeah, there are a number of countries which also have conducted very high quality seroprevalence survey, but Spain is one of the latest. We have finished with our formal presentation, so I think we should go to the questions and answers and to the comments. The first comment I can see from Dagmar from EMCDDA. She's asking about the, it's just a question to you, Julia, whether the link to the guidance on screening is available, if it's already published, and if there is any recommendations for people who inject drugs. Maybe if you can answer very quickly and then we go further.
Thank you. Thank you very much for that question. Yes, the guidance is already available, is online in the Ministry of Health, both in the strategic plan against hepatitis and also in the national plan on AIDS. And it's only in Spanish, although following advice from Antons and Marcelo, we are planning to translate it to English. And of course, people who inject drugs are one of the most focused population for testing, where we recommend testing them frequently, but also linking them to care. And the guidance includes best practices from different regions in Spain. And we've selected a number of good practices engaging people who inject drugs to the system by delivering care with mobile units like some of my colleagues have already described. Thank you again.
Thank you, Julia. Well noted, and thanks for taking an effort to translate. I think it will be really useful because that's one of the most often received question about the example of guidance on screening or testing for HCV we receive from other countries. So going back to questions and answers, there was another question about how the COVID-19 pandemic affected the delivery of HCV treatment in Ukraine, and Zhanna Tsenilova from the Alliance from Public Health answered quickly. I will summarize her answer, and she can add whether she wants, if she wants, that they have data only about 150,500 patients which are on treatment within the Alliance program, and then they had to stop the enrollment of new patients due to quarantine, but all the patients who were already on treatment, they continued to receive the treatment. And so there were no single termination during quarantine. And starting in July, there will be enrollment of new patients. If anybody has anything to add about the situation in Ukraine, please raise the hand, or we can write in the chat. So there was also another question about access to HCV treatment in Armenia from Oana Kerakasyan, and she mentioned that there was a donation to 500 patients in Armenia, and 1,000 are going to receive more. If anybody from the participants has, I see the hands raised. I think it's from Zaid, and I will allow him to talk. But if there anybody able to comment about the situation in Armenia, to add to what I said, I will give the floor. Now I'm giving the floor to Zaid, who probably wants to add something on Ukraine. Zaid, can you speak?
Okay, thank you. Thank you everyone for the nice presentation. I think it was really great to listen to all the experiences. So yes, I am Zahed. I'm based in Ukraine. So actually just wanted to add very little on what Zhanna was saying. I think we did have, due to the COVID situation, we did have some situation with the supplies. For example, you know, the regions, the cartridges for diagnostics were delayed, and you know, the people that we wanted to get on the treatment because of the quarantine, transportation was not available, and all of those things, people could not come to the clinic. So we had to actually distribute the drugs in a longer period of time than we would usually do. So it's not only for maybe Hep C, but it's also for most of the treatment that we were doing, especially for the people who inject drugs. Because, you know, those actually couple of months we had this situation that the quarantine was quite heavy. But I think it is, what has happened now, I think it is quite okay so far. But I think what we are looking at, a lot of problems which happened over the last couple of months, I think we are starting to see those effects happening now. For example, supply chain problem which happened in the beginning of quarantine, actually we are seeing the effect now. So I think we need to, why I'm saying it, in Ukraine, not on Hep C, but in other medication, we are seeing some sporadic supply chain disruptions on OST, on tuberculosis. So I think this is maybe also an issue that we need to maybe look at when we are looking at going forward, because problem was there, but we did not actually feel it because there were still supplies in the healthcare facilities. So over the next month or so, I think we're going to see those problems coming up. So we need to maybe kind of closely follow up on those situations. Yeah, thank you.
Thank you very much, David, for clarification. There was a question from Hugo about the WHO guidelines or guidance on the maintaining HCV treatment during the pandemic. And I just respond in this Q&A section, you can see, and I also provided the link. There is a WHO recommendations on maintaining essential health services during the COVID-19 pandemic, and there's some specific recommendation on hepatitis testing and treatment as presented by Nicole, and then you can check this document. Is anybody from the panelists willing to comment or ask or respond any questions? There is also a question to Julia, one more question to Julia. Have patients after liver transplantations prioritize to treatment before liver transplantation?
Can you repeat the question, please, Antons?
Have patients after liver transplantation any priority to treatment before liver transplantation? So it's, I'm not sure I can understand the question. Maybe the person who asked the question can raise the hand, and we will give the floor. And Julia, maybe if it's possible, you could share the link to the guidance, to the screening guidance in the chat, so the people.
I will do as soon as
okay.
Finish this, because I don't want to do too many tasks at the same time online.
All right. Okay. Okay.
Perhaps, Antons, regarding your previous comment, although I'm not that clinically oriented, currently in Spain, there are no restrictions to access DAAs. So it's a matter of clinical severity, and I presume that patients in clinical difficulties will surely be prioritized. So now in the COVID situation, I know we are all facing very difficult situations, but on the whole, Spain will provide treatment to everybody with a positive hepatitis C, irrespective of liver stage fibrosis.
Yeah, thank you, Julia. And I know that many countries in our region, the access to hepatitis C treatment has improved a lot in the last several years, and many countries we don't face now the problem with providing the treatment for the patients who are diagnosed, and we know that diagnosing those who are still undetected is becoming a major challenge, especially, or at least in the countries where resources are available. Yeah, thank you.
May I just add something?
Yes, Marta, please.
Yeah, sorry, but I just like to present the analysis that we just did, because we'd like to see what happened during the COVID epidemic anyway, because we want to stay on track towards elimination of viral hepatitis in Slovenia. And so the recent analysis has shown that in Slovenia there's a possibility of free anonymous testing for hepatitis C, B, and so on. And compared to the same period in 2019, between March the 1st and June the 30th, only 14% of the program was done in Slovenia. So 86% decrease in testing for viral hepatitis in 3 months period, the highest, the strongest period of COVID epidemic. I think many countries are now doing this analysis because it's really something that needs to be taken care of and not to proceed into the future months.
Thank you very much. And I see that Julia has just shared the link. I will share it with everyone to the guidance.
Anton, I'm sharing 2 links. Okay.
Okay.
I'm sharing the link to the survey and sharing the link to the guidance. I'm trying to do both.
I see. Just make sure you respond to all panelists and attendees so everybody who is online can receive. Otherwise, we will share it afterwards. We will send a follow-up email with some additional information to all the participants.
Thank you. Thank you.
Also, let me take just 2 minutes to announce there will be another webinar or mini summit that will be organized by WHO headquarters tomorrow. So you can see it will be tomorrow from 1 to 3:15 Central European time. So it will be high-level event to commemorate the World Hepatitis Day, and there will be a lot of high-level speakers. It will be focused mostly on the African region, but there will be also a session on the updates from the region, and also Dr. Masoud Dara will represent our region, who will who will present few examples from our compendium there, and we will share all the program and the link how to register to webinar just after this webinar. So anybody who is interested, you will be able also to join this global seminar tomorrow. So going back to our, there are 3 more hands raised, and so I will give the word to Anna Tsanilova from Ukraine. I guess she wants to add something about the. Jana, you should be able to speak now.
Thank you. Hello, can you hear me? Yeah, very nice.
Yes.
So thank you very much. It seems to me that it was already a couple of interventions from Ukraine, and probably that is enough. But I should probably add that all to the COVID situation. And of course, we did have some new things to face. And the most problematic was that we are working in the infectional hospitals or AIDS centers, as you know. And during the first months of COVID, they were most concentrated on COVID issues and could not spend as many time to our patients with the HCV as they can. But still, we did manage to organize everything decently, and all of our patients were getting treatment, regular DAs, and all the things. And not only this, they were all connected to educational services, which were provided by our case managers, social workers. And we even organized and published a very interesting informational material which was devoted to our patients. They were so creative during quarantine times that they even were just creating poems and pictures on how to avoid, how to prevent hepatitis, and how to stick to the healthy behaviors and all the things. And yes, I should just agree with the head that the supply chain is the most problematic issues we are facing now in Ukraine, related to HIV, TB, and HCV. But still, we are doing our best, and we are very happy to this. And thank you very much for organizing this interesting webinar, and for the compendium as well.
Thank you very much. Thank you very much, Jana. We fortunately we have to close. Maybe I can give a very brief 1 minute to Greet Hendricks from Wild Hepatitis Prevention Board before giving the final word to close the webinar to Dr. Masudar. And as I mentioned, we will share, we will send a follow-up email just after the webinar with all the documents, with the invitation to the global webinar, and also with the compendium, which is about to be published now on our webpage. So Greet, if you can be very quick, because we are running out of time. Over to you, Greet.
Do you hear me?
Yes.
So I can be very, very quick. As Mojca told us that there is an enormous impact of the COVID on the surveillance and the screening of hepatitis. I would like to ask her if she also sees this impact on the vaccination, so on the immunization. As for the World Hepatitis Day tomorrow, there is the focus on hepatitis immunization, on vaccination. It would also be good to know if in the European Union you see also this impact of COVID, and if we need to do some extra effort to increase again the vaccination and to not let COVID enter in this program, in fact. So
thank you, Greet. Yeah, thank you, Greet, for the question. Very important one. Well, we haven't analyzed that yet. However, I'm very closely connected to the organization of all the interventions in Slovenia during the COVID-19 pandemic for viral hepatitis. And as far as I know, for a very, very short period, there was a cessation of regular program of children vaccination. But it was perhaps a month or even less, but then we tried to adapt the regular vaccination according to the situation. So I think there won't be much decrease in vaccination, but as for testing, which is on private basis, it was really a disaster. That's why we are organizing just now, today and tomorrow, a huge campaign in spite of still COVID getting up in Slovenia for testing, free anonymous testing just at our clinic with all the precautions, to prevent coronavirus spreading. I think it's very important. We made a huge mass media campaign just to inform people that it will be very safe. Just come and get tested.
Thank you.
Masoud, maybe over to you. We are already 6 minutes out of time.
Oh, thank you very much, Anton. Carrie, if you have anything to add from your side, if not, I round it up. Any one sentence? Oh, okay, thank you very much. So I would like to thank all the panelists for your time and excellent presentation. I would like to thank all the participants, our interpreters, to make a bridge between us, English and Russian. I think I would like to leave with one message, and that message is a hope. You need to give a hope to millions of people who are living with hepatitis in our region, that you're not forgotten. We work hard to make sure, even during COVID-19 and beyond, the prevention, testing, treatment, and care is in place. So with those words, let's continue working together. There's also the Regional Collaborating Committee on TB, HIV, viral hepatitis, which issued a call for action. There are also other call for actions that we need to take on board and adapt the services for the population that we serve. Thank you very much for this, and have a nice day. And let's continue interaction offline. Thank you. Have a nice day, everyone.
Nice day.
Dr. Masood, just a second. The compendium just went online.
Good news, Marcelo. Thank you very much.
Put the link on the chat.
Very great time. Thank you.
Bye.
Thank you. Thanks, Marcelo, Antanos, Bellan. Thank you.